Okay, we're heading into the home stretch here on this section of the cardiovascular system. I'm assuming this will be our last video, but we'll see. A couple things. We talked about mean arterial pressure and its regulation. We talked about how it's homeostatically regulated and how we regulate both intrinsically and extrinsically, heart rate, stroke volume, and TPR. There's a couple other ways to look at this, and one of them is the long-term regulation. The long-term regulation of mean arterial pressure is primarily accomplished by blood volume. It's pretty simple. If we have an increased blood volume, we increase blood pressure. If we have a decreased blood volume, we decrease blood pressure. So as an example, one of the more common ways, especially up until recently, to treat high blood pressure, hypertension, was to give someone a diuretic. Diuretic is a drug that makes somebody go pee. So if it increases the urination, that's going to decrease the blood volume. If you have less volume in your vessels, that's going to have less pressure, and that's going to decrease blood pressure overall. So the long-term regulator of mean arterial pressure is blood volume through the kidneys. The short-term regulator is we're finding more and more that blood volume actually plays a greater role than we used to think. But the primary short-term regulator is something called the baroreceptor reflex. Baro refers to pressure, so these are pressure receptors, which makes sense because that's what we're trying to regulate is mean arterial pressure. So just as a reminder, all reflexes follow a reflex arc. We have a receptor, we have a sensory afferent fiber, right? There's the integrator, there's the motor or efferent fiber, and there's the effector. So the reflex arc has 5 components: 1 receptor, 2 afferent, 3 integrator, which is usually the CNS, 4 the efferent, and number 5 the effector. So if we look at that in terms of the baroreceptor reflex and look at it a little more specifically, the type of receptor is really easy. It's in the name, baroreceptor. Again, baro means pressure. So these are pressure receptors. They're located in the carotid sinus, the aortic arch, and a few other places like that. There's also some pretty good evidence that baroreceptors are also in the kidney. That makes sense since the kidney, through blood volume, is the long-term regulator of blood pressure, right? So one of the major nerves that serves the baroreceptors is the glossopharyngeal cranial nerve number 9. So if we have a change in pressure, the baroreceptors will sense it. That will send a signal through the glossopharyngeal nerve to the medulla. In the medulla, there's an area of cells called the cardiovascular center. And based on what's happening here, this is my integrating center, the cardiovascular center, I'm going to send out the motor efferent fibers signals to the effectors. We're going to look at the efferent fibers. This is primarily a autonomic function, so we'll talk about the sympathetic and parasympathetic, and the effectors would be theoretically anything that could help us change the blood pressure. So we'll look at that a little more specifically. So here's an example of the baroreceptor reflex, okay? And again, it has a number of different effectors, so let's kind of look. So here's an example of the baroreceptor again. There's our glossopharyngeal. Here's our medulla cardiovascular center for the integrator. And then my efferents are either the cranial nerves, especially cranial nerve number 10, the vagus, right? And that pretty much only goes to the heart. The other efferents, the other motor fibers, are the sympathetic, and those go to the heart, the vessels, the kidney, and the adrenals. So one of the things to remember is that the blood vessels, the kidneys, and the adrenal glands are examples of sympathetic only, as we've discussed in a previous section. So that's kind of the different efferents or motor fibers, and here's our different effectors. There's more you could put in here, to be honest, but the big ones are the heart, the vessels, the kidneys, and the adrenal glands. So let's kind of look at an example of how this works. So let's say the stimulus was an increase in mean arterial pressure of 10 millimeters of mercury. Okay, so if somebody's blood pressure, their mean arterial pressure went up 10 millimeters of mercury. So in that case, right, that would stimulate the baroreceptors. That would send signals through the glossopharyngeal, cranial nerve number 9, to the medulla. And the medulla received these signals, right? The response would be, since blood pressure went up, the homeostatic response would be to bring it back down, right? Back down to its set point. So to do that, we're going to have everything on this side go down. So on the right side, since the stimulus goes up on the left side, everything on the right side is going to go down. So I like to do the sympathetic first, even though it looks more complicated. It's actually pretty easy because it's direct. All right, and it goes everywhere. So if we have an increase in mean arterial pressure, my response is to decrease mean arterial pressure. So using the sympathetic system to the heart, it's going to decrease heart rate. This should be, say, chronotropic, not chromotropic. It's going to decrease strength. That's inotropic. It's going to decrease the conduction velocity. That's dromotropic. So if we decrease the strength, that's going to decrease stroke volume. Remember, mean arterial pressure is the product of heart rate, stroke volume, and total peripheral resistance. So if any of those values go down, mean arterial pressure is going to go down. Okay? Then instead of worried about the parasympathetic, I just complete the sympathetic. So sympathetic also goes to blood vessels. It's going to decrease, right? And if I have less signals to the blood vessels, I'm going to get dilation, which is going to decrease TPR. All right, remember those are inversely proportional. So if my blood vessel dilates, there's less resistance, a decrease of TPR. We're also going to decrease the sympathetic stimulation to the kidneys. In the kidneys, and we'll see this in the last section, that'll decrease blood volume. So what we're going to do is we're going to have more pee, right? And so if we have more urine excretion, it's going to decrease volume, which is going to help decrease pressure. In the adrenal glands, we're going to decrease the epinephrine release. Remember, epinephrine is released from chromaffin cells in the adrenal medulla, right? Oops, sorry. And so what we're going to do is we're going to decrease the amount of epinephrine. Now, epinephrine is a hormone. It's called a sympathomimetic because it mimics the sympathetic nervous system. And it helps to if there's less epinephrine, there's going to be less support of the sympathetic. So that's going to decrease all these things as well. We can't forget about the parasympathetic. I like to do that last. Since the sympathetic went down, it means the parasympathetic has to go up. The parasympathetic goes mostly to the atria, so it'll affect primarily the SA node and the AV node. And if we increase the parasympathetic, it's also going to decrease the heart rate. It's going to have a small decrease in the strength, and it's going to have a small decrease in conduction velocity. So that's the baroreceptor reflex. If you look at it the other way, if the stimulus is a decrease in mean arterial pressure, the response would be to increase it, and then everything on this side goes up, right? So that's, I'm not going to go through it. You can go through it on your own, but it's basically the exact opposite now. So remember that the stimulus and the response are going to be opposite. Sorry. One of the things that the baroreceptor responds to is what we call orthostatic hypotension. So orthostatic refers to change in position, hypo, low, right? Tension, pressure. So orthostatic hypotension is a drop in blood pressure with a decrease in position. So as an example, if you go from a sitting or lying state to standing very quickly, that tends to drop blood pressure initially. And the reason why is blood tends to, because of gravity, pool in the lower limbs. That decreases venous return, that decreases cardiac output, and that decreases mean arterial pressure. Once the mean arterial pressure goes down, the baroreceptors are stimulated to increase blood pressure back up. Now, in some people, if this is severe, and it happens in especially younger, fit females that tend to have a very relatively low blood pressure anyway, or really anybody with low blood pressure, but the predominant population tends to be young, fit females, and elderly. Elderly because they just have a blunted baroreceptor reflex, and also really, really good athletes. The more someone trains, especially in endurance training, the more blunted their baroreceptor reflex gets. And in some cases, those people can stand very quickly and actually faint. And so that obviously wouldn't be a good thing. And those people figure it out pretty quickly, and they tend not to stand quickly if they can help it. So the baroreceptor reflex is a very important reflex in terms of controlling blood pressure, especially short term. There's another reflex I want to talk about, and I think this is important because it ties a lot of things together physiologically, but you don't see it in too many books. And it's called the exercise pressor, or sometimes known as the exercise processor reflex. And what it does is it controls the partition of blood flow. Now remember, when we talked about partition of blood flow previously, it just said that takes blood and sends it to the areas of need primarily. And so the exercise pressor reflex is an anticipatory reflex. It has that feed forward control we talked about in the last section. So the first portion of this exercise pressor reflex is we have an increase in sympathetic stimulation. We also have a decrease in the parasympathetic stimulation, right? Remember, so they're sort of like on a seesaw. One goes up, the other one goes down. And so what happens is we get this vasoconstriction, okay, this global vasoconstriction, which is going to decrease blood flow because it's going to increase resistance, okay? At the same time, we get this this global venoconstriction. Now, when we're talking about venoconstriction, it doesn't really change the resistance of the vessel. What it does is it just helps to return blood to the heart. So we get an increase in venous return, okay? So that's the first thing that happens. And that stimulation then causes the release of epinephrine from the kidney, from the adrenal glands right above the kidney, and that's going to circulate and have an effect. The parasympathetic stimulation goes down, so that's going to affect the heart rate. Remember, this is rest, so the heart rate's probably below 100, so the parasympathetic has a big influence on that. And the other sympathetic changes are going to help us get us ready for exercise. And then what happens basically is once you have this global vasoconstriction, which is going to help increase blood pressure, as you start to exercise, you're going to produce those local chemicals, and those local chemicals are going to cause dilation. Okay, so we talked about all the local chemicals that are released in a blood vessel, around a blood vessel, cause dilation. And because of that, we're going to get something called active hyperemia. And that's because the local chemicals are generally related to metabolites. If we increase the exercise in an area, like a certain muscle is doing more work, it's going to have more of these local metabolites, which means it's going to have a greater effect on dilation. So we're going to get more vasodilation, which is then going to increase the blood flow to that area. So that's what active hyperemia is, an increase in blood flow due to an increased metabolic need. Right, so the exercise pressor reflex helps to partition blood flow. Again, we'll go, going the wrong way. Right here, we're looking at, your cardiac output of about 5 liters per minute. Remember, the cardiac output on average is about 5.5 liters per minute, which is equal to our blood volume, which is also about 5 to 5.5 liters per minute. So we actually kind of turn over our blood volume on average once a minute. And if you look, you can see that you got a 14% of your cardiac output going to the brain, 27% going to the digestive tract and the liver, 20% going to the kidneys, right? 21% going to skeletal muscle. So you have, a fairly large portion of your blood flow going to those areas, especially the brain, the kidneys, and the digestive tract. So between those, right, that's what, 60%, 70%, right? No, 60%. 60% of your blood going to those basically 3 areas. When you start to exercise, right, what you're going to do is you're going to increase the amount of blood that goes to the skeletal muscle, which is going to decrease the amount of blood to other areas proportionally. Okay, so that allows us to put blood to the areas where we need it most, and that's called the exercise pressure reflex. A couple other just odds and ends. One of the things that often confuses students a little bit is the difference between what's called arterial sclerosis and atherosclerosis. Technically, arterial sclerosis is any condition that's caused by deposits on the blood vessels, making them harder or less pliable. Okay? And most people assume that to be atherosclerosis. Atherosclerosis is specifically when those deposits are made from cholesterol. So that plaque is deposited on the arterial wall by cholesterol, and that causes problems. It narrows the lumen. We can rupture the deposits and cause a thrombus, or we call thrombosis. That's a stationary blood clot, right? Remember, thrombo means clot. Sometimes they're used interchangeably, but technically, atherosclerosis is not arterial sclerosis, but people use them interchangeably because most cases they are. And I'll give you, one, common example. The most common example would be you can have arterial sclerosis, this hardening of the arteries and this narrowing of the arteries, not due to cholesterol, but due to an increase in calcium deposits. And so technically that's not atherosclerosis because it has nothing to do with cholesterol, although certainly it is still dangerous. So that has to be taken care of. But because most cases of atherosclerosis are arterial sclerosis, people use them interchangeably. Okay? But especially for those of you getting into the clinical medicine, you should know the difference, but you probably, will hear them used interchangeably. Another common problem that we have is the idea of hypertension. Hypertension is high blood pressure. And that certainly is related to arterial sclerosis because it increases the risk for it. In order to have arterial sclerosis, you need to have some sort of vascular damage. So you need to damage the inner wall of a blood vessel. And one of the easiest ways to do that is high blood pressure. You can also do it easily in a number of other ways. And another common one is diabetes. Also will do that and increase the severity of any heart disease in someone who's diabetic than someone who's not. Clinically, hypertension nowadays is 130/80. Fairly recently, last couple of years, they changed it from 140 down to 130 because they found that people that had a lower blood pressure actually did better, in what they call morbidity. So they had less disease and they did better in mortality. They died less often. And that's true, to be honest, all the way down to any level of blood pressure until you start to be symptomatic for low blood pressure, like that orthostatic hypotension we just talked about. But the lower the blood pressure, the better, as long as you don't have any symptoms. So hypertension, about 90% of the causes are what we call idiopathic. We don't know what they are, where they come from. The cause is unknown, right? And so literally like idiot, we don't know, and pathic is the place it comes from. It's like 90% of them. So when someone is diagnosed with hypertension, there's really no specific protocol that they really follow because there's so many factors. It's called a multifactorial disease. There's so many factors that could be causing it. So that it certainly creates a greater risk. 10% of the hypertension cases are called secondary, and that's because they're linked to some other disease. So as an example, people with certain types of kidney disease will have secondary hypertension, and there's really no way to fix that. You can give somebody a new kidney, but you can actually, not going to happen because somebody who needs a kidney who doesn't have a kidney that functions, it's going to be much higher on that list than you would be in terms of that. So there's a number of other problems that happen with high blood pressure. Sometimes your baroreceptors adapt to the higher pressure, and that increases your set point. Like I said earlier, it damages the arterial walls, which leads to the cholesterol deposits. It also causes cardiac hypertrophy. Hyper means increased, trophy in this case is size. So hypertrophy is an increase in muscle size. And to be honest, just because your heart is bigger doesn't mean it's a bad thing. And so you could have hypertrophy from exercising a lot. And if you have this big, strong muscle in your heart, that's good. You could also have hypertrophy because it's enlarged, because it's trying to overcome a higher pressure to exert blood out of the heart. Then that is one of the problems that leads to heart disease and what they call cardiomyopathy, heart failure. And so long-term wise, those aren't good. One of the things that can happen if you have cardiovascular disease is what they call myocardial ischemia. So even though it looks like it says ischemia, right? It's a hard K, it's pronounced ischemia. So myo is muscle, cardio is heart, right? So that's heart muscle. And ischemia means lack of oxygen. So this means that somebody's not getting enough blood flow. That's almost always due to what we call arterial occlusion, that our arteries are narrowed from a disease process. It could be that we have a lack of cardiac output. If we're not putting out enough blood out of the heart, we're not going to get enough blood to supply the heart tissue. And in those cases, you often end up with what's called angina. Angina we talked about back in lab 1516 when we talked about referred pain, right? And so we said that oftentimes even though it's your heart that's not getting sufficient oxygen, that referred pain process leads to pain in your shoulder or arm, even though it's your heart not getting enough of that. If that gets bad enough, it can lead to what we call a myocardial infarction. That's the scientific name for a heart attack. And sometimes we try to use on someone's damaged heart stem cells to promote something called angiogenesis. So angio is blood vessel, genesis is make. And so sometimes we try to make new blood vessels to help supply the heart with oxygen. A couple other things that we can see that causes problems. One of those is called reactive hyperemia. Don't confuse this with active hyperemia. They look almost exactly the same except for that RE, those first two letters. Active hyperemia was an increase in blood flow due to an increase in metabolism, increase in metabolic need or demand. Reactive hyperemia is an increase in blood flow following occlusion. And this creates problems for a number of different reasons. What happens is when there's occlusion, there's a buildup of local metabolites that can cause excessive vasodilation, because those metabolites, remember, all of our metabolites are vasodilators. And then once we get rid of that occlusion, we get this rapid increase in blood flow, and we're finding it causes what's called reperfusion damage. And sometimes that reperfusion damage is greater than the damage of the occlusion itself. And one of the things, in terms of heart muscle has probably about 20 minutes where it can be anaerobic without damage. But once you get past about 20 minutes, you tend to have irreversible permanent damage into the muscles that don't get sufficient oxygen. So it is an issue trying to restore blood flow and restore oxygen without causing this reperfusion damage. There are a lot of ways to cause edema, right? And edema is a very common symptom of other things. And it can result from a number of different things. And we looked at this in lab 21 with the Starling forces. But basically, edema is swelling of the tissues. Again, in nursing circles, they often call it third spacing, although I don't think they use that term clinically at all. And that's when the filtration, right, we're pushing fluid out, is greater than the reabsorption. Okay, so we're normally supposed to push a little bit of fluid out, and that's picked up by the lymph system, cleansed going through the lymph nodes, and eventually dumped back into the subclavian veins and returned to circulation. But sometimes, for various reasons, we have an excessive amount of fluid there, and we just can't drain it fast enough. That could be due to a number of different factors. One would be an increased hydrostatic pressure. So if you had hypertension, that would lead to swelling, especially in what we call your dependent areas of your body, your legs. And there's other reasons why you could have swelling in the legs, but one of them would be an increased hydrostatic pressure, which is best estimated by your blood pressure. It could be decrease in blood proteins. Remember, proteins are osmotic regulators, and they help to pull fluid back into the capillary. If you have less proteins, you're going to have less fluid pulled back, so that could lead to edema. Another common one is an increase in capillary permeability. If the capillaries are more leaky, you're going to have more fluid. The last one, which you might talk about more in micro, would be an obstruction of the lymphatic vessels. If you can't drain your lymph vessels, then fluid's going to build up. And that often happens when someone has lymph nodes to be biopsied. It's called lymphedema for cancer or something. Or it could be, there's a couple microorganisms that can lodge themselves in the lymph system as well that will prevent drainage of fluid. And so elephantiasis is one of those. And if you've seen those pictures where people have these just very large swollen legs from that excessive edema, then you know what I'm talking about. So that's edema. One of the places you see this really common is in cases like this. So here's this very malnourished young child. And you think, okay, he's malnourished. I can see that in his arms and legs, but why does he have this big swollen belly? Well, what happens is normally when we send blood through the hepatic portal system, right? So remember, the portal systems are when we have two capillary beds in series, right? And so the first capillary bed is in the gut where we reabsorb, or not reabsorb, we absorb proteins from the gut in order to use them for various functions within the body. So someone who's malnourished doesn't have sufficient protein. And so what happens is as those proteins go through the hepatic portal vein, they help to reabsorb fluid from the abdominal cavity and help keep the abdominal cavity from excessive swelling. Well, when you're malnourished, you don't have nearly as much protein within your hepatic portal vein. So you don't pull that fluid back and it accumulates in the blood. And it's a disease called ascites. And that, not have to know that for the exam, but just, as an example, that's pretty common. So it's an example of the decrease in blood proteins. We also see that with alcoholics sometimes. It has to do with the liver and problems with the liver and cirrhosis, and that increases the pressure, which increases the pressure of the hepatic portal vein. But also oftentimes it is dietary related because especially at the end stages, alcoholics often get the majority of their nutrition through alcohol, maybe their calories that way, which obviously doesn't have much protein in it. So that creates the same type of problems. But you can see it in some with liver disease as well. So we've already talked about that. So that kind of finishes up this chapter. And so that's the cardiovascular notes, and that finishes us up.